leprosy is a really interesting disease, and you're quite likely to encounter a leprosy patient, but you won't encounter them very often. So that's the problem. How do we sensitize people to recognizing leprosy patients and leprosy presentations? So what I'm going to talk about is I'm going to talk about leprosy in the UK, and particularly about the presentation and diagnosis. And I also work at the London School of Hygiene and Tropical Medicine, and I run a global leprosy research program from there. And I'm particularly interested in the immune-mediated complications of leprosy. And that's particularly the reactions and nerve damage, and I should be talking about reactions. These are episodes of increased delayed hypersensitivity towards mycobacterial antigens, and they cause a lot of the nerve damage that's associated with leprosy. If leprosy was just a bacterial disease, then it would really be very easy to treat, and it's these immune-mediated complications that are really the challenge. We've also realised that actually a lot of patients have neuropathic pain, and that's something that really I've recognised sitting here in my clinic in London, where I've got a bit more time to talk to patients than you do in the field, and you realise that a lot of patients have pain that goes on for years after we've treated their leprosy, and that's led to some new collaborations with people here in London, but we've also done studies in India and Ethiopia on pain in leprosy patients. And we're also part of a global collaboration to study, again, one of the other complications of leprosy, ENL. And HIV and leprosy is very interesting. At the beginning of the HIV epidemic, we thought that there were going to be a lot of leprosy patients with co-infections. And actually, we wrote up one of the first patients recognised with leprosy and HIV who presented as an immune reconstitution syndrome, and he presented to the clinic in London. And what I'm glad to say is actually there have been very few cases since then, and we've been very lucky because we see it mainly as this immune reconstitution once patients have started heart. And actually I've spent many years in Ethiopia trying to recruit a cohort of co-infected patients, and it's been a very slow process. And we've also done work on the leprosy genome and collected some archaeological DNA from skeletons here in the UK. So people often ask, how did I get interested in leprosy? And the answer goes back to the teenage years, because I grew up in a small village in Worcestershire, and I was very bored there, and I wanted to escape. And I got a place at Birmingham Medical School, and I had a gap year. And the other thing was, this was 1970s, and like all kids in the 1970s, what I wanted to do was drop out and go to India. So I actually came to London. That was the first bit of the escape, and I worked as a cleaner at UCH, and I earned enough money for a one-way ticket to India, and I went to India in 1975 with £120 in my pocket. And I then did some volunteer work at a hospital, and the guy who was running the hospital said, look, leprosy is a really interesting disease, and at that time, parents would still abandon children with leprosy outside the hospital. And I stayed there, and we did hand and foot inspections of the leprosy patients every week. They're doing work on developing new drugs for leprosy. And I reorganised their pharmacy for them because it was a mess. And then I travelled around India and back overland. And I promised my parents that I wouldn't travel by myself, but of course I did, And I travelled up into Pakistan, up into the Swat Valley, where you couldn't go now, and then around Afghanistan, right up to northern Afghanistan, to Mazar-e-Sharif, and then across Iran. And by the time I got to Turkey, I was fed up with deserts, and so I got on a boat to Istanbul, and that left me with an interest in leprosy, an interest in travel, and an interest in India. And I've been very fortunate in that I've been able to combine those since then. And so I trained in medicine in Birmingham, and then went to Zimbabwe to work for one of my house jobs there, and then I came to London and trained in infectious diseases and specialised in tropical medicine, and then rather oddly went back to the same place in India for doing my my research. So these are the key facts about leprosy, and if you remember this, then the rest of leprosy is easy. And so leprosy is caused by Mycobacterium leprae, and what happens is that there are a few patients who are infectious. Most patients are not infectious because the bug is intracellular, and what happens is that the Lepromatous patients cough and sneeze their Mycobacterium out into the environment, and other people get infected. The next and really interesting point is that the kind of disease that people get is determined by the host immune response. And I'll show you that in detail. And people with good cell-mediated immunity have a disease with few lesions and low bacteria. It affects the skin and nerves, and so people present with skin lesions. You need to be able to suspect leprosy when you see unusual skin lesions, and they present with nerve damage, and so people can also present with new nerve damage. We're very fortunate because we've got very high cure rates with the current antibiotic treatment, so-called multi-drug therapy, and all leprosy patients are treated with either a dual or triple drug combination. But we have chronic damage to nerves, and that continues to be a problem, and it's very difficult to switch off the inflammation associated with leprosy. And this is the leprosy spectrum. And it was actually developed by my predecessors at the Hospital for Tropical Diseases, a team called Ridley and Jopling, and Dennis Ridley was a pathologist, and Harold Jopling was the leprologist. And what they realised was that you could classify patients according to their kind of immunity. So at one end, you have patients with tuberculoid leprosy. And the really bad part about the spectrum was letting a pathologist name a clinical form of disease. So these patients are called tuberculoid because when you look down the microscope, what you see are granulomas, and so it's nothing to do with tuberculosis. It's just a granuloma in skin and nerve. And these patients have very good cell-mediated immunity, and they have a very low bacterial index, and their disease is confined and localized. At the other end of the spectrum, we have patients with Lepromatous leprosy. And these people have very low cell-mediated immunity for Mycobacterium leprae, and so their bacteria multiply unchecked, and they have a very high bacterial load, and this is their bacterial load. And so they're infectious, and you see a lot of bacteria in their skin and nerve biopsies. There are also these intermediate types, the so-called borderline types, borderline tuberculoid, true borderline, and borderline lepromatous. And I wouldn't expect anybody to be able to differentiate between the different borderline types, at the end of this lecture. So it's easiest just to think of tuberculoid, borderline, and lepromatous. And then on top of that, we've got these immune reactions, and the borderline patients are at risk of getting these reactions. And what happens is that they develop increased cell-mediated immunity, and they move towards the tuberculoid pole, and with that, there's a lot of granulomatous damage to skin and nerves. There are also patients with type 2 or ENL reactions, and these are antibody mediated and almost sort of a vasculitis type picture, and they of course only occur in these patients who've got a high bacterial load. And this shows the type of skin lesions across the spectrum. So this is a single localized lesion. These are multiple lesions in the borderline part of the spectrum. And this is someone with Leprosy leprosy and the collapsed nose that's so typical of Leprosy leprosy. And this is the slide of tuberculoid leprosy, and this is what you see on the skin biopsy. You see granulomatous inflammation, and that, particularly around sweat glands, but also around the dermal nerves. And this is a tuberculoid nerve, and as you can see that the normal structure of the nerve has been completely destroyed, and you should see rows of straight axons, and they've been completely disrupted, and there's a huge giant cell in the middle there. And this is the picture that you see with Leprosy leprosy, so it's a very diffuse inflammation in the skin, but what's important is that you've got a lot of mycobacteria, and all these red dots, they're all mycobacteria. In fact, there are so many that they're clumping together into massive clumps. And this is a Leprosy nerve from a patient, and again, you actually have less disruption of the nerve architecture, but you've got a lot of mycobacteria again in the Schwann cells. So, what's the picture of leprosy in the UK? Well, as I've said, it's an important disease, and early diagnosis is important because the whole push for the global leprosy program is to detect patients early and to prevent nerve damage. And what's strange is that, of course, if you're in India, it's much easier to recognise leprosy than if you're sitting, here in, say, in Homerton Hospital. What I've shown from previous studies is that there's significant delay in diagnosing leprosy in the UK. So this is the HTD. When I started at HTD, we were still in the 19th century in many ways, and the hospital was in an old workhouse next to St Pancras Station, and we skipped the 20th century. We moved straight to the 21st century, and we're now in the UCH complex, and it's much better being part of a bigger team and part of the larger hospital. When we were there, we had to put patients in a taxi to go down to the Middlesex Hospital if we wanted an ultrasound. So we've seen about 400 patients with leprosy at the Hospital for Tropical Diseases, and we see a combination of three groups of patients. So we see newly diagnosed patients here in the UK. And then we have patients who are referred for management of their complications. They might have been diagnosed and treated elsewhere. And then we've also got a cohort of very old patients who were diagnosed pre-1995. We also have a nurse-led foot clinic because it's really important to do good foot care for the leprosy patients to prevent neuropathic damage. And we have an ophthalmologist. So, how do we diagnose leprosy? Well, the first thing is the history, and the history is very important. And you have to have lived in a leprosy endemic area. And I'll show you the map of that. Clinical examination is really the key to diagnosing leprosy, you look for skin lesions, so typical skin lesions which range from granulomatous through to nodules in the lepromatous patients. you look for thickened nerves because leprosy is really the only important cause of peripheral nerve thickening. You also get eye involvement with leprosy, and you can get involvement of the nose and the nasal mucosa in patients with lepromatous leprosy. And you support that by doing slit skin smears and histology. So we do slit skin smears when we make a little cut in the skin and take some dermal juice out and spread it on a slide and count the number of mycobacteria there. A lot of patients in the UK are diagnosed accidentally on histology. So a dermatologist will do a skin biopsy, just say, granulomatous lesion, query cause, and it's the pathologist who actually diagnoses leprosy. And the important thing is that there's no useful serological test. Patients at the lepromatous end of the spectrum do produce antibodies, and there are M-leprosy-specific antibodies, but the problem is that so many patients across the spectrum don't produce antibodies that you can't use it as a screening test. People also tried for a long time to develop a skin test, and a lot of work was done on identifying M-leprosy specific antigens and developing them into a skin test, and that has really not again been helpful. Again, the problem is that actually when you look in endemic areas, a lot of people have evidence of exposure to Mycobacterium leprae without developing a clinical disease. And people are also working at the moment, they're also working on sort of T-cell based ELISpot test, and the Dutch are working on that, but actually that also is only making slow progress. Leprosy reactions are also important, and so there's the type 1 with cell-mediated immunity. Type 2 is an immune complex disease, but people can also just have inflammation of their nerves, the so-called neuritis. We often see patients presenting with reactions before treatment, and that's why it's important to be aware of reactions. And we diagnose them clinically and support that with the biopsies and looking for histological evidence of inflammation. And we treat with steroids and thalidomide. Looking at leprosy in London from 1995 to 2011, we had 133 newly diagnosed patients then. And we've done clinical examinations, we've looked at the skin lesions. They all had peripheral nerve examination and a skin biopsy review by Sebastian Lucas, who's a very experienced tropical pathologist. And what we did was we looked at the ethnic and geographical origins of the patients and also the diagnostic pathways. So looking at the demographics, so these are all immigrants, and the mean age of presentation is 31, with a huge range, so 30 up to 79. If you're working in a leprosy endemic area, then the people who developed leprosy are in their late teens and early 20s. That's when there's a peak. We also always see more males than females in adult leprosy patients, so we also are reflecting that. What is very interesting is when we looked at times from symptom to diagnosis, that was about 2 years. So again, that's a very significant delay, and a lot of nerve damage will be occurring there. Again, we've had a huge range from 1 month to 15 years. And these are the main leprosy endemic countries. So all countries report their numbers of leprosy patients to WHO, and WHO produces maps of leprosy new case detection rates at regular intervals. And the important thing is to notice, just how widespread leprosy is. India is really top of the caseload. So India accounts for almost 60% of the world's leprosy patients, followed by Brazil with about 11%. Indonesia is the third most endemic country, and they report about 20,000 cases per year at the moment. But the point is that that one's seeing new leprosy cases throughout Africa and also in northern Australia and also in the States. And looking in London, what's interesting is that the places where people presented with their leprosy from, of course, reflected a combination of both the new case detection rates in their endemic countries and the patterns of migration to Britain. So India accounted for almost 30% of our caseload here in Britain, followed by Sri Lanka. But then Nigeria is the next highest, and that's again because there is still a lot of leprosy in Nigeria. Nigeria reports about 4,000 new cases per year, and there's a lot of migration from Nigeria to London. Does anybody want to guess why we've seen cases from the Philippines? What thing that the Department of Health did then was reflected in the leprosy clinic? Yes. So the Department of Health went on a recruitment drive in the Philippines, and a lot of Filipino nurses came over and worked here, and that was then mirrored a few years later by seeing leprosy cases in the Philippines, and the unrest in Somalia has produced immigration from Somalia, which also has very high leprosy. So these are the clinical signs that you should look at, and have as your mental checklist for leprosy. So people present with a range of skin lesions. Erythematous, if they've got a reaction, plaques, nodules, and infiltration. People present with nerve damage, and they often present with nerve pain or new nerve damage. So one of my Brazilian patients who presented to the rheumatologists at Northwick Park, she had a lot of pain in her ulnar nerves and loss of sensation on the ulnar border of her hand. People also burn themselves if they've got anaesthetic patches, particularly in the winter. They put their arm on a radiator, and that is another way in which you might present with reaction, with leprosy. And then reactions are important when you get edema of the skin lesions and joint involvement with arthritis. And nerve damage occurs across the spectrum. And it also occurs before diagnosis, and this is the real challenge. So, in the field, we find that about 20% of patients have got significant nerve damage at diagnosis, and then their nerve damage can get worse during treatment, and it can certainly progress after treatment. And we see nerve damage in really two different contexts. We see it in the skin, in the sensory and autonomic nerve fibers, and also in the peripheral nerve trunks, where you get the peripheral nerve trunk pathology or presentation just the same as if you've got an injury to the peripheral nerve. So you get motor weakness and regional sensory loss. And these are the nerves that are affected in leprosy. So ulnar, median, radiocutaneous. Anybody know where the radiocutaneous is? It's a nerve known only to leprologists. So it's a little nerve that comes just above the anatomical snuff box. It actually supplies sensation to the web of the thumb. And it's a peripheral nerve, and it's often involved in leprosy. So that's a useful little diagnostic point. Facial nerve is involved. Common perineal, which supplies the muscles in the feet. You get foot drop. And does anybody know what does the posterior tibial nerve do? Where is it, and what does it do? So the posterior tibial nerve is just behind the ankle. So there's just here, and it supplies sensation to the sole of the feet, and it's important. And because it's involved, the leprosy patients get foot ulcers. So we've also got a really neat way of assessing sensation in the leprosy clinic, and these are graded monofilaments, and they were invented in Brazil. And so you've got nylon threads at different weights that deliver a different load when you touch them on the skin. So you can do a quantitative sensory assessment. So you just put these in your pocket and go into the jungle and do a nice peripheral nerve examination. So I imported these from India to Mortimer Market. And has anybody used a monofilament? Not in the leprosy clinic. No. Not anybody used monofilaments? Yes. So they're now in diabetic clinics, and what's really nice is that there's been a process of reverse integration. So this low-tech thing, which was actually the Indian version, was bicycle spokes. So you had bicycle spoke with a little nylon thread on it. So the Brazilians sort of made them much better designed, and then they were taken up by the diabetologists here as part of screening for peripheral neuropathy. So I rather like that. So this is a Brazilian physio assessing the hands and feet of this patient. So what nerve is being tested there with those 3 points? Ulnar, yeah, and the median, and on the foot, posterior tibial, very good. So when we look at the nerve impairment patterns in UK, we see that the ulnar is the most commonly affected in terms of motor impairment, followed by the median and the lateral popliteal. When we look at the sensory impairment, again, over 30% of patients have got involvement of their posterior tibial nerve. So again, very similar to the patterns of nerve damage that we see out in the field. And when you look at how many impaired nerves patients have, most have 2 or 3, but there's a very long tail, and you can have up to 14 nerves involved, which is pretty unfortunate, but that's because you've got 7 nerves bilaterally. We also looked at contact with health services, and most of our patients in London, they'd first gone to their GPs, a few had gone to A&E and hospital, and dermatologists are the speciality who's seeing most leprosy patients, followed by neurologists and rheumatologists. Orthopods are very bad at diagnosing leprosy, even when their SPRs tell them that they should suspect leprosy. And I have to say that the infectious disease teams are not always great at diagnosing leprosy either. And when we looked at misdiagnosis, so we defined a misdiagnosis as when leprosy was not thought of in the differential diagnosis at the first consultant consultation. And we found that there was a high level of misdiagnosis amongst the dermatologists. And so these are various pictures of leprosy misdiagnosis. So this lady had a large red red plaque on her cheek, and she was misdiagnosed as erysipelas. And you can see why that diagnosis was made to begin with. But actually, if you took a good history from her, she'd had a small lesion on her cheek that had been present for 4 years. And what had happened was that it had suddenly expanded and become red. This lesion didn't respond to 4 weeks of antibiotics, and a biopsy was then done, and she was diagnosed on the biopsy. This lady had a diagnosis of lupus vulgaris made, and the dermatologists quite often mistake lupus vulgaris for leprosy. Again, they don't test for sensation in the patch. And this was the young Brazilian woman whom I've already mentioned. So she presented with neurological symptoms, and so she had loss of power in her hands and feet together with pain. And what do you think that pain indicates? So what structures are affected in leprosy? Skin and nerves. Yes, nerves. Okay. So if you've got pain in your elbows and knees, what's together with loss of power in your hands and feet, what might be happening? Yeah, so you got a neuritis. So she had neuritis in her ulnar nerve, which was presenting as elbow pain, and she also had some swelling of her joints, and she had this rash, and she had a vasculitis screen that was negative, and she had nerve conduction studies done, which showed the mononeuritis multiplex, and that was that together with the skin biopsy gave the clue. And then this lady presented to a rheumatological clinic, and she was misdiagnosed as vagus granulomatosis. She had nasal symptoms, and she was given, and she actually had a biopsy, and nobody stained for Acinetobacter bacilli on the original biopsy, and she just continued attending the clinic with the symptoms and nodules, and eventually she was at she was seen by somebody who wondered whether she might have a mycobacterial infection, and a biopsy was done, and she was then diagnosed as leprosy. And what happened was that she was then under our treatment, and she had a very stormy course. But unfortunately, she preferred the diagnosis of vagus granulomatosis, and so she would come in with reactions, but to say that she had vagus granulomatosis. So how can you avoid missing leprosy? Well, leprosy patients can present for a long time after leaving the leprosy endemic area. So, Claire was talking about how you should think about Vivax for a couple of years, and I would say, well, you need to think of leprosy for up to 20 or 30 years. Very interesting association between the UK and India, and 50% of our patients come from the Indian subcontinent. That also reflects the global distribution of leprosy. So, of course, if you're working in Holland, then you'll see leprosy patients from Indonesia, and the French see them from Francophone Africa. If you've got an undiagnosed granulomatous skin patch, test it for anaesthesia, and that will help you diagnose leprosy. And you should also do skin biopsy in anybody with pigmented skin and an unusual skin lesion, and that will help you diagnose leprosy. But you need to warn the pathologist, because the pathologist won't necessarily do the stain for Acinetobacter bacilli. You should also think of leprosy when you see an unexplained neuropathy, and you should consider leprosy as a cause of unexplained foot ulcers. And leprosy can also present with joint syndromes, and if you're elsewhere, then there are various. These myself, Nick Beeching, and Mark Bailey will all see patients in whom you might suspect leprosy as a diagnosis. So treating leprosy, the easy part is treating the infection. What's far more difficult is treating reactions and nerve damage, because we're not very good at switching off the inflammation associated with leprosy. You need to do a lot of work with people to present them getting neuropathic damage, but it's worth it. So last September I saw a Punjabi carpenter with new leprosy, and he'd been misdiagnosed for 5 years actually, and he had significant loss of sensation in his hands. He now had weakness in his hands, and he'd had to give up his job as a carpenter. I talked to him about preventing getting damage to his hands and feet, and how he should be very careful with the temperature sensation. And I saw him in clinic last week, and he came along with his son, and I said, you haven't got any ulcers now, and he said, and the son said, no, we've been really careful, since you told us in September about particularly protecting ourselves against a temperature that they'd managed to avoid ulcers, and that was really encouraging. Of course, teenagers are far more difficult, and it's difficult to get health education messages across to them. We also have to do a lot of work to reduce psychological support and reduce stigma. And I've got actually two doctors with leprosy from the Indian subcontinent, and they both don't like having leprosy at all, and they find their diagnosis of leprosy, even though they've been treated, very difficult, and they keep coming along with alternative diagnoses. And it's very interesting because that also shows the deep feelings that are associated with leprosy. So this is the multi-drug therapy, and these blister packs are supplied the world over free from WHO, and they're paid for by Novartis, but they're very cheap. So Novartis get an easy win there. And in 1982, a very good WHO decision was made that all leprosy patients should receive multi-drug therapy, and that's been very important. And so people either get triple drug combination of rifampicin, clofazimine, dapsone for 12 months, or a dual combination of rifampicin and dapsone. We're also incredibly lucky because we have a very high cure rate. The cure rate is at 98% in terms of killing the bacteria. Not all the lesions improve, and that's related to the inflammation, and we don't really have any significant drug resistance. So again, very different scenario to TB, and about 16 million patients have been treated with multi-drug therapy since 1982. So these are the immunological complications that I've mentioned briefly. So there's the type 1 reactions with edema of the skin lesions, then type 2 which is an immune complex problem, and you get painful red nodules and a lot of pain, and then you can get this the neuritis. And we've looked in India a large cohort of patients and shown that people can get these new immunological complications so this is months on the bottom, so months after starting treatment. So everybody was started on multi-drug treatment there, but even though you're curing the infection, you're still at high risk of developing these immune-mediated complications. We've also got the global collaboration, and London is part of that, looking or studying patients with erythema nodosum leprosum. And we've got partners in India, Bangladesh, Nepal, Philippines, Ethiopia, and Brazil. And we're recruiting patients prospectively. We've already recruited over 250 patients with ENL, and that's the largest prospective study that's been done ever of ENL. and we've been collecting data on their clinical features. And then one of my students went to India the year before last and interviewed patients about the household cost of having one of the complications of leprosy. And what we found was that patients who had this immunological complication of leprosy, 33% of them, the household, was tipped over into catastrophic expenditure. So again, this also ties in with the importance of the private sector in India and the importance of providing free drugs and free access for healthcare. And there's still prejudice in the UK, and this was the headline in the Sun a few years ago, and they still use the word leper. The word leper is quite often used by newspapers, and so we've been trying to work against that with social marketing. We also know that women are doubly affected by having leprosy, and they're at a much higher risk of being stigmatised and having adverse complications. We've worked with Public Health England to produce a memorandum on leprosy, which summarises many of the points that I've made here. About referral and diagnosis and what to do if you think that you've got somebody who might have leprosy. So just to summarise, leprosy continues to be imported into the UK, and the geographical origins of our patients reflect leprosy caseloads in the home countries. Diagnosis is delayed. Dermatologists and neurologists are key professionals in diagnosing it, but as ID physicians you will be asked about possible diagnosis of leprosy, and we see all kinds of leprosy in the UK. And finally, we're trying to combat prejudice, and this is the Victoria Hislop, who wrote a novel about the Greek island at Spinalonga, about leprosy patients there, and I was actually the medical advisor on the book, and she ended up winning lots of prizes with it. But what has been really helpful is that it's been a very good way of combating prejudice in the UK. Thank you.